agreement with the medical director that permits them to initiate, titrate, and discontinue medications. And they're also allowed to order and interpret laboratory tests for managing common primary care conditions. And then usual care is what you would expect. It's physicians, nurse practitioners, and physician assistants that focus on the diagnosis of undifferentiated complaints and urgent care visits. So typically a patient will first see their usual care provider to get diagnosed with a medical condition, and that provider will then initiate a medication to treat that condition. Then the provider will refer the patient to follow up with the pharmacist within the clinic so the pharmacist can manage their medications. This not only alleviates the workload from the provider standpoint, but it also allows pharmacists to practice at the top of their license. So time and target for systolic blood pressure range, I'll be referring this as TTR for systolic BP. It's a novel measure of arterial hypertension management, and time and target range incorporates both the average BP value prevailing during long-term follow-up and the degree of BP variability. It's separated into 4 separate ranges. So 0 to 25%, 26 to 50%, 51 to 75%, or 76 to 100%. So from a performance measure perspective, blood pressure control is often determined using only the last recorded blood pressure of the calendar year. So this is problematic as blood pressure is a continuous measure that fluctuates over time, and the last recorded measure may not adequately reflect control or lack thereof over time. Furthermore, several studies demonstrated that the greater variability in systolic blood pressure is associated with CV outcomes. So the optimal measure of systolic blood pressure control would account for variation both within and out of target range. The mean of multiple systolic blood pressure measurements over a specified period may be within target range, even if none of the individual systolic blood pressure measurements fall within the range. Let me just check the chat real quick. So the current literature landscape. So the idea of the study came from 2 separate studies. Both involved our very own Dr. Dixon, who's on the call right now. So the first one was, I'll be referring this to as study 1. It is titled The Impact of Pharmacist-Physician Collaborative Care Model on Time and Therapeutic Blood Pressure Range in Patients with Hypertension. And the second study, I'll be referring this as study 2, or Fatani et al. It was titled The Systolic Blood Pressure Time in Target Range and Cardiovascular Outcomes in Patients with Hypertension. So for study 1, the objective was to determine the effect of a PPCCM on TTR for systolic BP compared with the usual care group. For their methods, it was a post hoc analysis, and they compared data obtained from 2 retrospective groups of patients with uncontrolled hypertension managed by either PPCCM or usual care, and there was a 12-month follow-up period. For the results, the mean TTR for systolic BP was 46.2% plus or minus 24.3% in the PPCCM group, and 24.8% plus or minus 27.4% in the usual care group, with the p-value less than 0.0001. There are greater reductions in BP were observed in the PPCCM group compared with usual care. For systolic BP, it was negative 27.8 versus negative 11.4 respectively, with the p-value less than 0.0001. And for diastolic BP, it was negative 19.2 versus negative 4.2 respectively, with also a p-value of less than 0.0001. So BP control rates at 12 months were 89% in the PPCCM compared with 50% in the usual care group, also with the p-value of less than 0.001. So in conclusion, patients within the PPCCM group had higher TTR for systolic BP compared to those within the usual care group. So next is study 2, and the objective of this study was to estimate the independent association between time and systolic blood pressure target range and major adverse CVD events among adults with hypertension. So for methods, this was a post hoc analysis of the SPRINT trial that compared intensive and standard systolic blood pressure treatment interventions in adults with hypertension and high CVD risk. So for the results, participants with time and target range of 75 to 100% had lower 10-year CVD risk. For every 1 standard deviation increase in time and target range, it was significantly associated with the decreased risk of first major adverse CVD event in fully adjusted models. And the time and target range remained significantly associated with major adverse CVD events, despite adjustment for mean systolic blood pressure or systolic blood pressure variability. So in conclusion, they found that time and systolic blood pressure target range independently predicts major adverse CVD event risk. So for the first question, what are pharmacists in the Pharmacist-Physician collaborative care model implemented by Dixon et al. Allowed to do under their collaborative practice agreement for the management of hypertension? Is it A, order laboratory tests, B, initiate medications, C, discontinue medications, or D, all of the above? And then you can just feel free to answer in the chat. Seems like everyone is answering correctly, and that is D, all of the above. So the point to really notice here is that this was a comprehensive collaborative practice agreement. They could initiate meds, order tests, and we want to keep that in mind when we think about the dissemination of the program, as well as why we may or may not see economic value associated with this type of program. Unlike some limited collaborative practice agreements, this isn't just titrating meds. It's pharmacists really practicing at the top of their license to provide the best care to patients with hypertension. So based off these two studies, my question was, can we model the impact of PPCCM on costs and CV outcomes? So despite the available evidence supporting PPCCM as an effective model at improving TTR for systolic BP compared to usual care, and that patients with higher TTR for systolic BP have a decreased risk of adverse CV events, there has been no pharmacoeconomic analysis that has combined these findings to model the cost effectiveness of PPCCM. So for study aims, I wanted to compare the cost effectiveness of PPCCM with usual care hypertension management for the prevention of non-fatal myocardial infarction, stroke, heart failure, and cardiovascular disease or disease death. And I was going to look at it from the payer perspective to quantify the value added to a payer of covering PPCCM services. So for study design, I used a decision analysis model comparing PPCCM and usual care for hypertension management. And then I did a cost effectiveness analysis and a cost benefit analysis. So a decision analysis is defined as a systemic approach to decision making under conditions of uncertainty. Decision analysis requires that the decision maker explicitly structures the decision, then uses quantitative techniques to identify the decision option with the greatest expected benefit. Calculation of the greatest expected benefit considers both the probability that this benefit will be attained and the value of the benefit if it is attained. So because it deals with decision-making in uncertain conditions, decision analyses are based on the probabilities or likelihood of outcomes. And because it is a predictive technique, decision analysis cannot determine what the best choice will be. It can only determine which of a number of options is most likely to be the best choice. So this is a choice with the greatest expected benefit. So I used a decision analysis model to conduct two different pharmacoeconomic analyses, a cost effectiveness and a cost benefit. So for the cost effectiveness analysis, it's a way to examine both the cost and the health outcomes of one or more interventions. It compares an intervention to another intervention or the status quo by estimating how much it costs to gain a unit of a health outcome. And this can be a life year gained or a death prevented. Within my cost effectiveness analysis, I looked at how many CV events could be averted. And then for my cost benefit analysis, this compares the cost of two or more alternatives that have different outcomes. Both benefits and costs are measured in monetary value. So the objective is to find out what alternative offers the greatest return to investment. It's often used to compare services or programs since it is difficult to assign a monetary value to benefit of a drug therapy. So within my cost benefit analysis, I looked at whether PPCCM or usual care for hypertension management offered the greatest return to investment. So although the title of my research does state cost effectiveness, I would like to preface that a bulk of the research does deal with the cost benefit analysis. So for the cost benefit data, we start off with an intervention. So that would be the hypertension management. For the PPCCM group, they saw the pharmacist 6 times per year and 1 time with the physician. And then for the usual care, they saw the physician 3 times per year. For consequences, it was a TTR for systolic BP, where they would end up in one of the 4 ranges. And then for the health outcomes, it was a CV outcomes. So they could have no CV event, non-fatal MI, stroke, heart failure, or CVD death, and all CV events are mutually exclusive. So for methods, this is the decision tree. This decision tree model was developed in Triage Pro. So we first begin with hypertension management. The small blue square is known as a choice node, and that indicates the decision maker can decide whether the patient will undergo hypertension management by PPCCM or usual care. And then within each hypertension management program, there's a probability that the patient will fall within one of the 4 ranges of TTR for systolic BP. And then within each range, there's a probability that the patient will experience one of the CV outcomes. The green circle is a chance node, and it indicates that the events to follow are probabilistic events that are not under the control of the decision maker. So although the published data on the effectiveness of PPCCM had a 1-year study duration by Dixon et al., subjects in the model were assumed to stay in the same quartile of the targeted blood pressure range over the 3-year time horizon to facilitate the linking of the PPCCM effectiveness data to the clinical data on the association between TTR for systolic BP and CV events. The 3-year time horizon was consistent with the follow-up duration from the SPRINT trial, and it also aligns with the shorter time frame, utilizing cost effectiveness models from the payer perspective. So for the clinical inputs, data on TTR for systolic BP quartiles and CV outcomes were derived from the post-hoc analysis of the SPRINT trial. As you can see here, the PPCCM group has significantly less patients within the 0 to 25% range, and significantly more patients within the 76 to 100% range of TTR for systolic BP compared to that of usual care. Then for more clinical inputs, this was the probability of CV events by TTR for systolic BP. So the outcome event rates of patients in TTR for systolic BP 0 to 25% was taken from the SPRINT trial. And then the hazard ratio of patients in TTR for systolic BP for the other 3 ranges were taken from the study by Fatani et al. And just by looking at the base case values, you can see that the patients within the 0 to 25% range had a much higher chance of experiencing a CV event compared to those within the 76 to 100% range. And then patients within the SPRINT trial were censored after their first CV event, precluding analysis of subsequent events. And accordingly, CV events in this study were assumed to be mutually exclusive. So patients who did not incur one of these 4 events were assumed to have no major CV event. So for cost inputs, so the model incorporated direct medical costs, which included programmatic costs, direct costs of provider time, and downstream healthcare utilization associated with CV events. For the cost of the PPCCM program, patients were assumed to have seen for hypertension management 6 times per year by the pharmacist and once per year by the physician. And subjects in the usual care group were assumed to have seen the physician 3 times per year. So the cost per pharmacist visit reflected the CPT code 99211, which is a level 1 code, and it's an incident 2 billing code used by pharmacists given the lack of provider status and eligibility to bill at a higher level. And then for usual care, the CPT code that was used was 99213, and this is used for the evaluation and management of outpatient visits. So for more cost inputs, these one-time costs of treating each CV event were obtained from the cost effectiveness analysis of the SPRINT trial. And then the cost of hypertensive medications were assumed to be the same for both PPCCM and usual care, given the lack of comparative medication use data and hence excluded from the model. And then all costs were inflated to 2020 USD using the medical care component of the consumer price index. So for the one-way sensitivity analysis, a one-way deterministic sensitivity analyses were performed on all model variables to account for any uncertainty in the parameter estimates for the two hypertensive management options. A one-way sensitivity analysis is when you vary the values of one estimate across its reasonable range while holding the values of all other estimates constant at their baseline value. The baseline value is the value of the estimate used in the original decision analysis, which is the best estimate of the value. I used the range of plus or minus 20% based on previously published literature, and it was a more reasonable approach. However, the range can be up to plus or minus 50% if you choose to have a greater range. So if the result stays the same or varies little across the full range of reasonable estimates, then we can have a greater confidence in the result. However, if the result changes substantially across the range of the estimate, our confidence in the result is reduced. So for TTR for systolic BP, the base case was from published data, and we did the sensitivity analysis of plus or minus 20%. For CV outcomes, both the base case and sensitivity analyses were from published data. And then the no CV event was based on assumption. And then cost of PPCCM and usual care visits, the base case was from published data from ASHP and CMS with the sensitivity analyses of plus or minus 20%, and costs were adjusted for inflation. And then for the one-time cost of CV events, both the base case and the sensitivity analyses were from published data, and also, once again, the costs were adjusted for inflation. So for the results of the cost effectiveness and cost benefit, our study reported that for every 10,000 patients with hypertension managed in a PPCCM model, 21 non-fatal MIs, 29 strokes, 12 incident heart failure diagnoses, and 27 CVD deaths are expected to be averted. In base case analyses, PPCCM hypertension management was associated with a lower total program cost with a difference of $108 and lower downstream medical expenditures with a difference of $162.82 when compared to usual care. So overall, with the cost benefit ratio, it was dominant, so PPCCM was less costly to administer and resulted in downstream healthcare savings relative to usual care. So to explain what dominant means, I've included the figure on the right, the cost effectiveness figure. So the x-axis is effectiveness and the y-axis is cost, and there are 4 quadrants. In quadrant 1, there's a trade-off since the alternative option is at a higher cost but has greater effectiveness. In quadrant 2, the alternative option is dominated since it's at a higher cost and is less effective. In quadrant 3, there's also a trade-off since the alternative option is at a lower cost, but is less effective. And then in quadrant 4, which is where our results ended up being, the alternative option is dominant because it's at a lower cost and it has greater effectiveness. So next, for the sensitivity analysis, I would like to preface that all the sensitivity and threshold analyses that I'm about to discuss are based off the cost-benefit analysis portion of this study. So this is a tornado diagram of the incremental effectiveness of PPCCM versus usual care. So the tornado diagram graphically displays a series of one-way sensitivity analyses from the variables which change the answer from the greatest extent to those variables that have the most minor impact on the answer. So when the answer ranges for several variables stacked from lowest to highest, the results mimic a tornado. Of all the variables included in the cost-benefit analysis, it was most sensitive to the probability of usual care in TTR for systolic BP 0 to 25%, probability of MI in TTR for systolic BP 0 to 25%, probability of MI in TTR for systolic BP 51 to 75%, and the one-time cost of stroke. So next we have another sensitivity analysis, and this was the incremental cost of pharmacist-physician collaborative care model versus usual care. So the program cost of hypertension management with PPCCM, while lower than those of usual care and base case analysis, were sensitive to the number of visits with a physician for the usual care patients and a pharmacist for the PPCCM patients. So due to the substantial difference in CPT code reimbursement for pharmacists versus usual care visits, a patient in the PPCCM group that was seen 6 times per year by a pharmacist and once per year by a physician was still cheaper than a patient in the usual care group that was seen 3 times per year by the physician. So this is one of the first threshold analyses, which was for the unit cost of PPCCM visits. So a threshold analysis is a special type of one-way sensitivity analysis. A threshold analysis finds the value of the estimate at which the expected values of all decision options are the same. The threshold analysis is a type of break-even analysis. At the threshold value of the estimate, all options are equal. Threshold analyses can be useful in determining how far from the baseline value the estimate's value must be for the results of the decision analysis to change. So in this threshold analysis, the cost of the PPCCM and usual care programs become equal when the unit cost of the pharmacist visits increases by 62.5%, which would be to $39. So originally, the base case value was $24. So now we have two more threshold analyses. The one on the left is for the number of PPCCM visits. So if a patient sees the pharmacist 10 times or more per year, then it is no longer cost savings compared to usual care. And the next one on the right is for the number of usual care visits. So usual care is cheaper if the patient visits the physician less than twice per year. However, that is quite unlikely, just because based off published literature, typically for a patient with uncontrolled hypertension, they do see the physician at least twice per year. So question number 2, if payers reimburse PPCCM only for the patients most likely to show cost savings, which patient would we expect to be eligible for the service? A patient with pre-hypertension, B, a patient with controlled hypertension who had one hypertension-related physician visit last year. C, patient with uncontrolled hypertension who had one hypertension-related physician visit last year. Or D, patient with uncontrolled hypertension who had 4 hypertension-related physician visits last year. And you guys can feel free to answer in the chat. For those of you who answered D, that is correct. A patient with uncontrolled hypertension who had 4 hypertension-related physician visits last year. So for the discussion, PPCCM had twice as many clinic visits, but given current pharmacist reimbursement rates, they still incurred fewer program costs. PPCCM is associated with lower downstream healthcare expenditures, and payer coverage of PPCCM services can provide a positive return on investment. So comparing these results with past cost-benefit analyses on PPCCM. So one of the studies was by Polgreen et al., and it was a cost-effectiveness analysis from a societal perspective. And they actually determined costs based on time spent with pharmacists and providers and their average compensation rates. And they actually reported that provider costs over a 9-month period were $238.96 for PPCCM patients and $113.67 for usual care patients managed only by a physician. And then this other study that I will not even attempt to say the last name, but it was a cost utility analysis from a payer perspective that they determined costs based on time primary care physicians and pharmacists spent providing direct patient care and collaborating specialist time for direct patient care during acute care visits, laboratory tests, antihypertensive medications, and any overheads. And they actually also reported provider costs over a 9-month period were $345.25 for PPCCM patients and only $111.84 for usual care patients managed only by a physician. So both of these studies actually used time-based costing, which resulted in higher provider costs among PPCCM patients than those in usual care, because pharmacists do spend a longer time interacting with their patients. However, for my study, I utilized CPT codes in my analysis that generated higher expected costs for physician visits. However, this does accurately reflect hypertension management costs from the payer perspective because they do utilize CPT codes. So question number 3, how did our costing of pharmacist time differ from published studies? Is it A, our costing was based on expert opinion of the value of pharmacist time? B, our costing was based on average pharmacist wage? C, our costing utilized CPT incident to billing codes? Or D, our costing was the same as published studies? And you guys can, once again, feel free to answer in the chat. Okay. For those of you guys who answered C, that is correct. Our costing utilized CPT incident to billing code. So the value proposition for PPCCM, first off, there can be downstream healthcare savings. So our finding of downstream healthcare savings is consistent with the majority of economic evaluations of clinical pharmacy services for chronic disease state management that incorporate long-term healthcare expenditures. And next is also better health outcomes. So pharmacists delivered medication management and hypertension education have consistently been shown to reduce blood pressure, which in turn is associated with CV events. And then next is decreased physician workload. So by allowing pharmacists to help manage patients with chronic conditions, this definitely alleviates the physician workload. Physicians will then have more time to treat more complicated patients or work on their other administrative tasks. And finally, the ability to reach underserved populations. So there's a significant health professional shortage in rural areas, and people living in these areas do rely heavily on their pharmacists for their healthcare needs. So therefore, pharmacists are in a unique position to fill the shortage gap and reach these underserved populations. So next steps for the payer, which would first be reimburse pharmacist services with the CPT incident to billing. So CPT incident to billing, in which the physician bills, receives payments, and then will reimburse the pharmacist. This offers payers an opportunity to implement payment for services within the existing frameworks of physician reimbursement. So the use of incident to billing and collaborative practice agreements may also reduce barriers to PPCCM implementation from the pharmacy perspective, as a lack of clear reimbursement was cited by study authors as a potential barrier to more widespread PPCCM dissemination. So we did have a reviewer ask when we submitted this manuscript for publication, who would skeptical payers cover PPCCM services for? So given that the cost of PPCCM hypertension management exceeded the cost of usual care among patients with only one hypertension-related physician visit each year, payers concerned with the immediate budget impact of PPCCM reimbursement may focus on coverage for patients with at least 2 or 3 hypertension-related physician visits annually, as PPCCM is cost neutral and cost savings, respectively, in these populations. So question number 4, which of the following was true about the cost of PPCCM? Is it A, PPCCM had lower program costs because pharmacists met with patients fewer times per year than usual care providers? B, PPCCM had lower program costs because pharmacists are reimbursed at a lower rate than usual care providers through incident to billing? C, PPCCM had higher program costs than usual care because pharmacists met with patients more times per year than usual care providers? Or D, PPCCM had higher program costs because pharmacist time was valued at a higher rate than physician time? You guys can feel free to answer in the chat once again. So those who answered B, you guys are correct. So there were some limitations to my study. There is definitely differences in study demographics for the TTR for systolic BP data that was collected from a study with a very small population of only 112 patients, with 56 patients in each PPCCM group and the usual care group. And also CV outcomes collected from the SPRINT trial had a large population with a more diverse background. We did not incorporate the cost of medications due to lack of information. And since hypertension is a chronic disease that's often linked to multiple CVD events, we actually only included the first occurrence of a CVD event. So this may have underestimated the impact of PPCCM on long-term adverse CV events associated with TTR for systolic BP. And then for future research, we can quantify the costs associated with medications to identify their impact from the payer perspective. So the cost benefit of PPCCM with the addition of hypertensive medication costs should also be explored. So different CV outcomes can result in additional hypertensive medications, which can then impact the cost from the payer perspective. And also a Markov model investigating recurrent CV events over a lifetime. So our study was only designed to evaluate the first occurrence of a CVD and or death. Therefore, future research that includes a Markov model investigating recurrent CV events could be conducted. My current plan for my thesis, I actually just finished building the Markov model. And this will be in addition to the cost effectiveness model. And then this will hopefully strengthen my findings that PPCCM is more cost effective than usual care in hypertension management. So this is the Markov model that I built. So the theory behind it was that using a decision tree analysis undervalues pharmacist services. So by conducting a Markov model over a patient's lifetime could potentially fully capture the value of pharmacist services. And then although the manuscript for this research project has already been accepted by JMCP, hopefully I will publish a commentary on this Markov model, and then the cost effectiveness analysis and the Markov model in combination is my master's thesis that I'm defending in April. So overall, in conclusion, this was the first study to evaluate the cost effectiveness of PPCCM compared to usual care on TTR for systolic BP in adults with hypertension. PPCCM was less costly to administer and resulted in downstream healthcare savings and fewer acute CV events relative to usual care. And pharmacists are in a unique position to bridge the gap between the health professional shortage in rural areas and physician workload. And that is all that I have for you guys. And if you guys have any questions, I'm more than happy to answer.
Thank you so much, Dr. J.
No problem.
Anyone who has any questions? Oh, I see we've got one in the chat already. Do you think you could calculate a pharmacist's relative value unit from the time spent in the two studies?
Time spent in the two studies. Oliver would have to look into what a pharmacist's relative value unit is, because I'm not sure what that is. But if it could be calculated, I don't see why not. I don't know if Dr. Patterson knows how to do that or not.
Yeah, I'm honestly not familiar with that approach either. So I'd be definitely curious to look into that.
Yeah, this is Dave here, and hi, Starling. I think it would require having the amount of time spent with the patient, or the amount of time that the care required, and we didn't have that information. Certainly, there are some reasonable estimates out there that could potentially be used, but we were, I think, trying to really look at this from a value perspective and not quite so much in the kind of fee-for-service RVU model. But it's a good question and something worth looking at for sure.
Hi, this is Ben. I had another kind of question for you. And first of all, thank you for doing this analysis. I think you've done some great work here. If I understand things correctly, the analysis suggests that kind of the break-even point for the cost-benefit analysis would be $39 of billing, kind of a CPT code that would generate $39 of revenue. Is that correct?
Yes. And as of now, based off CPT code, the current reimbursement is $24.
Okay. And so if we were to look at the PPCM model as if it were a drug and had a drug cost, per year, I think that most payers would accept a drug with additional costs if it did lead to better outcomes. Is there a way of figuring out what would be the break-even point from that perspective, or is that we've already done with that $39 figure?
Are you asking if I included the drug costs within?
Well, I guess I'm saying, is there, if the intervention were more costly for the pharmacist to be involved in this manner,
Mhm.
How far could we generate additional costs going to pharmacists, not just in a break-even analysis, but more of a cost effectiveness analysis?
That is a great question.
For sometimes we say that if we could, if the drug costs were, $50,000 per quality adjusted life year,
Mhm.
sometimes that's considered a cost effective intervention.
Mhm.
Is there the ability to do a similar type of analysis with this?
We could potentially do something because we do look at like the number of cardiovascular events averted. I did not include utilities within this model, but that is also something that could potentially be added into the Markov model to look at. I don't know if that answers your question.
So some of these questions, can you hear me?
Yeah.
So these are really good questions. One of the things you're doing with modeling is she had a specific question she wanted to answer. And one of the things we have found over time is your models continuously evolve depending upon new information that occurs. And all these things are things that actually could be done, calculated if we had a specific purpose to do that. What she did was a fairly good question is, does this make sense, is essentially what it is. But we could figure out ways of calculating relative value units, but we'd have to gather more information. Her model is attempting to answer the question with the information that's available to her at that moment, readily available. If she had more resources, she was working within an institution, if she had more time, money, then all these things could very easily be answered by Jessica and the team.
Well, and Jess, you might want to share, you mentioned that you didn't incorporate qualities or utility values. If you could, there are utility values available for things like MIs and strokes. Like we could try to model cost per quality based on the avoidance of those events. If there were a set of utility values that would better equip you to do a cost utility analysis, what would that set of utility values be? I might not be asking you right, because I know you know the answer. Let me rephrase.
Okay.
Do you have utility values associated with the different time and therapeutic ranges? So like a utility value for someone who's in range.
That's what we don't have. Yeah.
So ideally, if we could get that, then that would even set us up, I think, to be more successful in showing even greater cost utility in terms of cost per quality, because we wouldn't just be dependent on preventing events. We'd actually be improving quality of life just by improving, your likelihood of being in therapeutic range for a long amount of time.